Good morning, everyone, or good afternoon, depending on where you are. Thank you for attending the Canadian Women's Heart Health Alliance Atlas Epidemiology, Diagnosis and Management of Cardiovascular Diseases in Women webinar series. Today, we are highlighting our latest chapter publication. It's chapter 5, entitled Sex and Gender Unique Manifestations of Cardiovascular Disease. My name is Dr. Sharon Mulvey, and I'm a cardiologist and professor of medicine at Dalhousie University, and the past chair of the Knowledge Translation Mobilization Working Group for the Canadian Women's Heart Health Alliance. Today, I am co-moderating this session with my colleague, Dr. Colleen Norris, and she's the co-editor of this series with us. And she's a professor and clinician scientist with the University of Alberta's Faculties of Nursing, Medicine, and School of Public Health in Edmonton, Alberta. And she's the past chair of the Health Systems Policy Working Group for the Canadian Women's Heart Health Alliance. A few technical notes before we get started. All of you have been muted and the video sharing capabilities have been turned off just to minimize disruptions during the presentations. And we've also disabled the chat during the presentations. For the questions, we are going to be putting them in the Q&A box, and we would encourage you to put the questions in during the entire time of the talk so that we can be addressing those as we go along and being able to get it all set up for our engaging discussion session. We would like you to make sure if you're having any sound difficulties, you could actually pop that in the Q&A box if you're having any problems, but check your own audio system first if possible. We would also like you to please, at the end of the session, you will be provided with a link to the evaluation form, and it's really important that you complete this evaluation as it helps us in our planning for future educational sessions, and we really value your feedback. And finally, the webinar is being recorded, and the recording will be available next week along with the other webinar sessions, the previous 3 that we've done. And we've happy to bring them to you from across our great nation. And you can find all of these located at the wearredcanada.ca website. So today, our learning objectives. If you can advance the slide, please, Lisa. Oh, I'm sorry, I forgot. First, we're going to do the land acknowledgement, and I would ask Colleen, please, to do this.
Thanks so much, Sharon, and welcome everybody. In her book, Braiding Sweetgrass, Indigenous Wisdom, Scientific Knowledge, and the Teaching of Plants, Dr. Robin Wall-Kimmerer reflects on the meaning of land to Indigenous people and rights. In the settler's mind, land was property, real estate, capital, or natural resources. But to our people, it was everything. Identity, the connection to our ancestors, the home of our non-human kinfolk, our pharmacy, our library, the source of all that sustained us. Our lands were where our responsibility to the world was enacted. It was sacred ground. It belonged to itself. It was a gift, not a commodity, so it could never be bought or sold. These are the meanings that people took with them when they were forced from their ancient homelands to a new place. Therefore, we would like to begin by acknowledging the Indigenous people of all the lands that we are on today. While we meet today on a virtual platform, we'd like to take a moment to acknowledge the importance of the lands which we each call home. We do this to reaffirm our commitment and responsibility in improving relationships between nations and improving our own understanding of local Indigenous people and their cultures. From coast to coast to coast, we acknowledge the ancestral and unceded territory of the Inuit, Métis, and First Nations people that call this land home.
Thank you, Colleen. That was beautiful, inspiring, and sobering. Today, none of the presenters have any disclosures that are relevant to the content of this presentation. Our learning objectives today are as follows. We're hoping that by the end of the webinar, you'll be able to be aware of how heart disease can be experienced by sharing in one woman's very personal journey. And we very much appreciate her being with us today. Also, to understand how the symptoms of ischemic heart disease can be different in women and how this can impact on the diagnosis of cardiovascular disease. And then to summarize some sex and gender associated and unique aspects and key features of the manifestations of different pathophysiologies that we see in cardiovascular disease in women. Next. I think most of you are aware of the Canadian Women's Heart Health Alliance, but just quickly to review, it's hard to believe that it's just not even four short years ago that we were established. And actually, I'm really proud to say we have accomplished a lot. Our mission is to disseminate education and best practices regarding women's cardiovascular health and disease processes among healthcare providers, and most importantly, amongst women with lived experience. And our ultimate goal is to eliminate knowledge gaps in specific cardiovascular disease issues and develop new practice considerations and practice patterns, even hopefully culminating in guidelines to be able to improve care for women, for all women in Canada. Next. We organized with 4 working groups, and I've already mentioned 2 of those to you today because Colleen and I are the past chairs of 2 of them. The Knowledge Translation and Mobilization Working Group has been key in developing and reviewing scientific information and presenting a scientific statement. And you'll hear more about that subsequently. Actually, the atlas came out of the abundance of information that we uncovered in preparing that statement. The Health Systems and Policy Working Group is to work with government bodies and other institutions that can affect change over time. And we have worked closely together with these 2 working groups to actually come up with this series of the Atlas epidemiological and manifestations of cardiovascular disease in women. And of course, you're all aware of the Advocacy Working Group, which is seminal in having established Wear Red Canada. And I hope most of you participated with us this last February 13th, and looking forward to next year's and in perpetuity until we don't have to do this anymore. And of course, Training and Education Working Group is key to be able to disseminate the information at all levels. From the, particularly in the professional healthcare providers, because it is sorely lacking at the current time. So from medical schools, through residency training, through CME programs, and also in the public domain. Next.
So in these discussions, it's really important for us to understand a distinction between sex and gender. And so when we're talking about sex, we're talking about this biological construct, and it's what you are assigned at birth. It's usually referred to as female or male, what your chromosomes are, and it encompasses hormones, genes, anatomy, and physiology. Gender, on the other hand, is a social construct and is referred to as man or woman or other. It's culturally specific and temporal, and it is actually a confluence of many dimensions, including gender role, gender relations, gender identity, and institutionalized gender. So all of those form to create who we present to the world and how it influences our health. Next slide, please. So the Canadian Women's Heart Health Alliance Atlas is 9 unique chapters. You're hearing chapter number 5 today, and it's all published online on CJC Open. And we are so grateful to Dr. Michelle Graham, who was with us from the start and has set up a separate spot on CJC Open for women's heart health. First publication happened in April 2020, and then we are going to do annual chapter updates. We really want it to be a living document. The 9 chapters are listed here, and as I mentioned, next slide, please. Today, we are going to be discussing chapter 5, specifically focusing on the sex and gender unique manifestations of cardiovascular disease. Over to you, Sharon.
Thank you, Colleen. And you know, one thing I forgot to mention that is so important in the setting up of the working groups that has enabled us to accomplish this work is that we have co-chairs for each of the working groups, and 2 co-chairs, and one is a patient advocate co-chair and the other is a health professional co-chair. So this has really enabled us to, I think, advance this work in a much more impactful way. So along that line, it gives me great pleasure to introduce Ms. Bobby Jo Green. Bobby Jo is originally from Cape Breton, Nova Scotia, just a little bit away from where I am today. But now she lives way out west in Edmonton, Alberta with her family. She's an elementary school teacher and an avid runner, and was misdiagnosed for the better part of a decade and this unfortunately interfered with both her career and her running. Her symptoms started in her late 20s, and she finally received an official diagnosis of microvascular disease at the age of 38. She will share with us her profound story, insights, and recommendations as a woman with the first-hand lived experience of heart disease. Majo, welcome and thank you.
Hi, thanks so much for having me today. As Dr. Mulvey said, I was experiencing symptoms early on, probably my 28, 29 years old. And it was very odd symptoms when it began. I just had some really vague things happening, like I was really, really tired, and I would get some chest pressure that would come and go. And that kind of all stayed, kind of stable until I had my daughter in 2013. So I was 32 years old. My diagnosis actually is endothelial dysfunction, a myocardial bridge, and coronary artery spasm. I did have a suspected diagnosis of microvascular disease for about 5 years, but then officially had my diagnosis when I was 38 to be a provocative angiogram. So after my daughter was born in 2013, I really started to experience some more concerning symptoms. I would have a lot of exercise intolerance, which was very weird for me because I was a runner. I was very active. I was teaching all the time. I was on the go with my kids all the time. And I was the running coach at school and running for leisure. So it was really odd to me that I was having this exercise intolerance. I was getting shortness of breath and air hunger, and just having a lot of difficulty with headaches and nausea. And this kind of went on for months, really for months. And I went and I kept getting checked out, and they were doing my ECGs, and they were doing chest x-rays and blood work, and everything was totally normal. So I was told that it was stress. I had just had a very traumatic pregnancy. So everything was just chalked up to stress. And, this is what it feels like to be a new mom. And this is what it feels like when you're, wearing all the hats and doing all the things. And at the time, I totally believed that because I was stressed. There was a lot on my plate at the time. However, it was probably about 8 months later of this really, these vague symptoms. And then I was cleaning cabinets at my home in Cape Breton. And all of a sudden, I had almost every single symptom of a woman having a heart attack. I had the contraction feeling in my chest. It was unmistakable. It was into my left arm, my wrist, my jaw, my chin, my back. I had the feeling of doom. I had this sense of anxiety, and I had the sweating. So my mother immediately gave me some aspirin to chew, and then she took me to the emergency room. When I got there, they did the ECG right away, and everybody was super excited because it was what they said, wonky. So the doctor was coming in, the triage nurses were there, one of the EMT workers came in, and they were asking me all these questions. Have you flown recently? Have you had a recent surgery? Have you been immobile for so long, or anything like this? And I knew immediately that they were looking for a pulmonary embolism. So they redid my ECG 2 or 3 times, getting the same result. And then they went and got a new machine and brought the new machine in, thinking that machine was broken. And similar readout, just not as severe. The ST elevation wasn't as severe. So they took me up right away for an X-ray and drew blood, and then checked the ECG again. And then this time it was a very, very mild ST elevation. So after the whole ordeal, I was told that it was stress, it was anxiety, panic attacks are horrible. Here's some Ativan, here's some muscle relaxers. And they gave me a pamphlet on stress management, and I was sent home. So this was the first of many trips to the emergency room. And over the following months, I would continue to have these types of events with the full-on cardiac, like the chest pain into the arm, into the back, and also the constant chest pain every single day. So my symptoms were initially always fobbed off as it's stress. I was told over and over again, it's stress, especially when those ECGs would come back okay and the chest x-ray would be okay. And you know, it was attributed to my pregnancy. It was traumatic, and it was most emotionally, you know, emotionally traumatic. So it was all fobbed up to, it's your pregnancy, it's stress, hormones, you're sad and you're upset and you're, you know, and you're anxious. So I had, I needed to get out of this. So I kept kind of going back at this point, and I kept going back. And I finally had a referral to a cardiologist. And oddly enough, the way I got that cardiologist consult was by taking my husband with me to emergency this time, because I needed somebody to vouch for me that I wasn't crazy, that I wasn't stressed out, that I wasn't a raving lunatic. So I had my husband come with me, and just by the luck of the draw, I had a female ER doctor. First time I'd had one, and that's when I got my referral for a stress test. It was the first time. But prior to that, and even then, she admitted, you know, this isn't cardiac because you're having right-sided chest pain. This isn't cardiac because your pain, you know, you're also having pain in your teeth at the same time. Maybe you need to go see the orthodontist. And, you know, it isn't your heart because you have pain with arm movements, and that's not, you know, that's not cardiac. You're having pain after exercise. Angina is felt during exercise. It can't be your heart. So, you know, I was told all these things. You can't have heart disease because your heart pain or your chest pain is during rest. So all these things that were happening to me were fobbed off as non-cardiac because they were atypical. And I don't like to use that word, but they were atypical. So I didn't fit the picture at all for your typical heart disease patient. And to the doctors, I had anxiety causing chest pain, not chest pain causing anxiety. And that was very difficult to get past. So I would spend the next few years in this, you know, fighting the medical system and in a holding pattern of the GI doctor, and then, you know, go see what the hematologist has to say. And then we're going to check out what neurology has to think. And then maybe immunology might have something to say. And then it would always refer back to the rheumatologist saying that I have fibromyalgia, and a psych referral, and then the pain clinic. And I was caught in this holding cycle for years, and it was just on repeat. So during that time, I did have a lot of misdiagnoses like costochondritis, fibromyalgia, regional pain syndrome, somatization, and of course, all of which would eventually be proven to be incorrect. So for those years, all I heard was, you're too young for heart disease, you're too fit for heart disease, you have no risk factors, you're healthy, your tests are normal, and Mrs. Green, there's nothing wrong with you. And that took a toll on me mentally. This would just cast doubts in my head, you know, various times throughout my journey. And I remember going to bed and, you know, giving myself pep talks saying, there's nothing wrong with you. There's nothing wrong with you. Stop doing this to yourself. You know, what is wrong with you? Because I was believing that there was nothing wrong with me, and everything that I was feeling was in my head. And I felt like a failure. And my marriage was struggling. I lost so many friendships because, you know, they were believing the doctors and not me, and I didn't get the support that I needed. So I just remember at this time too, calling HealthLink and talking to the nurses that they knew me by name, you know, and they would just ask me, did you get that psych referral yet? Did you go see that psychologist yet? And, you know, I sat in exam rooms while listening to the internist, you know, getting ready to come in and see me, and just having this exasperated, like lengthy sigh before walking into the door, like, not her again, not her again. You know, I've had stress tests. I went for the stress test, and during the stress test, I had chest pain. I had left-sided chest pain. I couldn't breathe. I couldn't catch my breath, but the machine said my heart was okay. And because of that, I was sent home with Tylenol. You know, I've been accused of drug seeking. I've been accused of cocaine, using cocaine, because cocaine users are the only people who have coronary artery spasms. So unless you're doing cocaine, you can't have coronary artery spasm. So it really took a toll on me mentally to just be gaslit the entire time and told that I'm crazy or that I'm drug seeking or what you're feeling isn't real. And it was very real. So I finally found a woman online, searching online, and I found her, and she had very similar symptoms to me. And this is where things kind of changed. She took me on board and I joined her Facebook support group. And there, it was like this renewed sense of hope and a renewed sense of persistence, you know, that I could do this. And in this group, not only did I get support and information and opinions and options, I got the name of a doctor who would change everything for me going forward. So that doctor was Dr. Tara Sedlak, and she's out of Vancouver, heart health specialist for women. So I emailed her right away. I was so concise. It was like I was studying for a test when I was getting this email ready. I had everything on there, all my symptoms, what makes it better, what makes it worse, what's happened, test results, and I sent everything to her. She was very quick to reply that, yeah, she believes me, that it is my heart, and that I should come down and see her right away. So I did. I packed up my little family and we drove down and we saw her, and she was everything I needed her to be. She listened to my entire story. I think I was there talking her ear off for an hour. I told her everything. She was apologetic that I've gone through this. She heard me. She listened to me. She addressed my fears. She addressed my fears of longevity with this. She gave me options and she gave me hope. So I'm very thankful for her. And the only issue that came from that was that the meds she was suggesting didn't work too well for me. Either I was having side effects or they just weren't helping with the chest pain. But then I would meet another roadblock when I came back here to Alberta, because the ER doctors and the specialists here weren't very keen on accepting a diagnosis based on assumption or suspected diagnosis. I had no test that said that I had this. And then they were still relying on those tests that were saying that I didn't have it, so much so that I had meds taken from me in an emergency room once that that Tara Sedlak had procured for me outside of the country because this med wasn't available in the country at the time. And they were taken from me, told it was dangerous. So I still had to kind of traverse that whole landscape afterwards. How do you deal with a misdiagnosis with doctors who still don't believe that you have heart disease, but a heart specialist who does believe you have heart disease? So, and again, it was Dr. Tara Sedlak who kind of gave me the information that here at the Mazankowski Institute here in Alberta, they were going to be doing a special kind of angiogram that could test my heart under different stressors and possibly give me a diagnosis. So she let me know that information, and then I let my GP know, and I have a wonderful GP right now. I was so lucky. It was a complete fluke, and he's there for me. He called and he sent some referrals right away, and they got back to me immediately, maybe a day or two later, and they needed me and I needed them because they were, going to start doing this new test. And that's when I got my official diagnosis of endothelial dysfunction, a myocardial bridge, and coronary artery spasm. So much so that I watched my artery completely clamp shut on the screen as it was being done. So things are still difficult as a woman, as a young woman, in this medical system. And at least now, though, I have an answer and I know how to advocate for myself, especially with the support systems I have in place now, like the online support groups and an amazing cardiologist that I can consult with, who is very, very well-versed expertise in heart disease and women's heart disease. So yeah, that is my story. It is my heart. It was my heart. It always was my heart. But because I was a woman and because I was too young and too healthy and too fit, it was all in my head for years.
Wow. Bobby Jo, thank you so much for sharing that story. I too apologize that you've had to go through that. And I am so glad that you were able to get connected with Dr. Sedlak. I know that there's going to be a lot of questions and discussion in the following panelist and session, and I really appreciate you being with us. Thank you. If we could have the next slide, please. So it gives me great pleasure next to introduce Dr. Christine Pacheco. Christine Pacheco is a cardiologist at the Pierre Boucher Hospital and Centre Hospitalité de l'Université Montréal, CHOUM, in Montreal, and a faculty member in the Department of Medicine at the University of Montreal. After earning her medical degree and completing her internal medicine cardiology training at the Université de Montréal, Dr. Pacheco successfully completed a fellowship in women's heart health at the Barbara Streisand Women's Heart Center at the Cedars-Sinai Heart Institute in Los Angeles, California, where she was mentored by Dr. Noelle Berry-Mertz. And I might also add that that was where Dr. Tara Sedlak was also mentored with Noelle. She acquired specialized training in the diagnosis and treatment of cardiac conditions affecting women, and she's currently the co-chair of the Knowledge Translation and Mobilization Working Group. I begged her to take that position on after I stepped down, and I am so appreciative and glad that she has, but she was voted in to do it as well. She is a member of the Executive Board of the Heart and Stroke Foundation's Quebec chapter, and she's one of the founding members of Quebec's first integrative women's cardiovascular health center at CHOUM. Christine, could you please enlighten us and know how to be able to work through the challenging conditions that our women patients come to our cardiovascular centers?
Thank you so much, Sharon, for that introduction. And thank you so much to Bobby Joe for the courage and sharing your story today with us. I think it's super important for other women and physicians from all across the country to hear stories like this, to really understand the impact that misdiagnosis and diagnostic delays can have in women like Bobby Joe and others. So today we're going to overview the chapter 5 of the Women's Heart Health Atlas that was recently published. And we're going to kind of overview ischemic heart disease, heart failure, valvular disease, cardiomyopathies, arrhythmias, vascular disease, stroke, and cognitive impairment with regards to sex differences in symptoms, diagnosis, and treatment of these diseases. So I'll go to the next slide, please. We know that heart disease is on the rise, and it's the leading cause of death for women worldwide. And Canada is not excluded from these statistics. When we look at World Health Organization mortality data, we can see that in Canada, as well as other countries, mortality is consistently on the rise. So some of the explanations for that are going to be addressed throughout the presentation today to kind of try to understand what are the differences that might account for this. When we look in terms of each specific disease, in terms of prevalence, our chapter presents the numbers for Canadian statistics. We know that ischemic heart disease is more prevalent in men, but women are often more symptomatic and different symptoms, and we'll get to that in the next couple of slides. And acute myocardial infarction and heart failure and stroke are also slightly more prevalent in men, but they do affect women, and they affect women differently. We can see also that cognitive impairment, which is a healthcare burden on only terms of caregivers and patients themselves, but also to our healthcare system, is more prevalent in women. When we talk about ischemic heart disease, what are we talking about? We're talking most of the time about stable angina. Angina is referred to chest pain or chest pain symptoms. And we also include in there acute coronary syndrome, which is commonly known as a heart attack. So when there is a blood clot or a disruption of the circulation to the heart muscle, which causes damage of the tissue of the heart. Ischemic heart disease represents higher mortality in younger women. Women between the ages of 20 to 74, so that is quite the age range, are at higher risk of dying following a heart attack than men in our country. Ischemic heart disease is also responsible for 3 times a higher mortality rate than breast cancer. Women are very aware of their risk of breast cancer and get checked regularly. And that is awesome because the mortality in breast cancer has declined as a result of these campaigns, but we need to do better for heart disease. Women also experience longer diagnostic delays between the time they get to the emergency room and they get their first EKG, between the time that they get their first EKG and they get an angiogram because they're having an acute heart attack. And that all contributes to the differences we see in mortality and morbidity. So why are there diagnostic delays and why are there differences in mortality for women? We know that heart attack symptoms are unfortunately not recognized in over 50% of women because women are more likely to present with more symptoms than just chest pain, which can unfortunately sometimes veer off the diagnosis when they're initially being evaluated by physicians. And as Majo explained to us, her symptoms were chest pain and discomfort, but also pain in the jaw, in the teeth, in the neck, in the arm. And these are symptoms that are most often reported by women, and they're more likely to have chest pain, yes, but also other symptoms that accompany their chest pain, such as abnormal sweating, shortness of breath, or even stomach pain. They might complain of indigestion or nausea. And this can sometimes veer off physicians and they're given Pepto-Bismol and discharged when in fact the symptoms were coming from their heart. Other accompanying symptoms or associated symptoms in women, which are more frequent, are unusual weakness or fatigue, back or shoulder pain, sleep disturbance, dizziness, or fast and irregular heartbeat. In our chapter, we present the differences in terms of numbers between women and men regarding these symptoms. So women who have heart disease or a heart attack do most often present with chest pain. It's 87% of women who present with chest pain versus 90% of men. So it's a big majority of women that will present with chest pain. They also present with neck or jaw pain, diaphoresis, which is excessive sweating, or shortness of breath. They are, however, more likely to describe nausea, unusual fatigue or weakness, indigestion, dizziness, as well as heart rate. And these are all more frequent in women and can contribute to, unfortunately, veering off from the fact that they are indeed having heart disease and heart disease symptoms. Women are also more likely to report what we refer to as prodromal symptoms. So in the weeks or days before a heart attack or a heart event, women are more likely to report unusual fatigue, sleep disturbance, as well as anxiety and arm weakness and heaviness. And these differences are reflected not only in the numbers, but also in the stories that we've heard, such as the story that Majo shared with us today. So because women have a higher likelihood of presenting additional symptoms, and they're not always the classic textbook symptoms, not the Hollywood heart attack that we often see in men with the extreme chest pressure and other symptoms, they have often been labeled by physicians and by terminology in medicine to have atypical chest pain. And this typical versus atypical chest pain is issued from older studies in the 1960s and 70s, where they used symptoms to kind of predict the occurrence of blocked arteries or not. And this classification was mainly studied in men, and it's disadvantaged women in the last 100 years, I would say, to get a proper diagnosis and to get properly evaluated. And women will often also describe their symptoms differently than men. They might not say pain, they might say pressure, burning. And because physicians have been so fixed and taught into this scheme of atypical versus typical, that can contribute to diagnostic delay. Fortunately, society guidelines, which are the publications that guide physicians on how to evaluate and treat patients with chest pain, are moving away from this terminology, and they're moving towards terminology that is more inclusive and that can allow physicians to better evaluate cardiac versus possibly cardiac versus non-cardiac chest pain. This guideline is the chest pain guidelines from the American College of Cardiology, which was recently published in the last year, right after our chapter, actually. And it's great to see that there is some evolution, but more work needs to be done. Here we can see that the likelihood should be based on different characteristics of the pain, not necessarily only exertion, it's in there, but other characteristics, such as the characteristics described by patients of the pain. And it goes from a higher likelihood of having an issue with heart vessels to a lower likelihood, depending on what is being reported. Women also have different risk factors. We addressed these risk factors in detail in a webinar on chapter 4. Women have certain pregnancy complications that can put them at higher risk for heart disease, things like earlier menopause and inflammatory diseases, which affect mostly women. As well as cigarette smoking and diabetes have an increased elevation in risk of having heart disease. And if you would like more information on this, please do refer to our chapter 4 webinar recording, where we go over this in detail. And finally, women have different causes of heart disease, which are often misdiagnosed or not diagnosed properly on conventional exams, such as the basic treadmill or the basic angiogram. Some of these heart diseases include things that also occur in men, such as coronary artery disease, valvular disease, and arrhythmia, and we'll get to those later. But women are more likely to have things such as spontaneous coronary artery dissection. That's a cause of heart attack that occurs in over 90% of women. Coronary vasospasms, such as Bobby Joe, had finally had diagnosed after so many hurdles. Small vessel disease of the heart. So the big vessels seem to be open, but it's the small vessels that are dysfunctional. And then stress cardiomyopathy, as well as peripartum cardiomyopathy, and we'll get to those a little later. So here are the classic findings of a heart attack in a male patient, mostly. Women can also have this type of heart disease. But what we see here, indicated by the arrow, is a conventional angiogram. So it's a test where we put iodine in the arteries of the heart to color them and to see if there's any blockages. And here there seems to be a big blockage in a major large artery, which is formed likely by cholesterol or fat deposits in the artery, and which is easy to spot and easy to treat. We would unblock it with a stent. This is a classic finding, mostly in men, also in women, but it's heart disease caused by coronary artery disease, which is easy to spot, easy to treat on a conventional exam. When we look at women, mostly, men can also have this type of heart attack. However, we do the angiogram and we don't find a major blockage. There's no big fat, obvious cholesterol deposit. However, both of the patients are having a heart attack. So so that brings me to talk to you about heart attacks when there is no obvious blockage on a conventional exam. What is the underlying cause? Previously, most of the time, it would kind of be, okay, there's no blocked arteries, a pat on the back, it's probably nothing, false positive, ECG, maybe not diagnostic, we don't really know. That we didn't find anything, all good, and the patient would be discharged, and this mostly affects women. However, we are realizing now more and more that when someone presents with what looks like a heart attack, it probably is one, and there can be different underlying causes to explain it that are not obvious on a conventional test. There can be small blockages of cholesterol that are not visible to the naked eye on an angiogram. There can also be small thrombi or clots that are not visible. There can be spasms, such as Bobby Joe's story, that are not obvious and must be studied using specific substances that are given during the angiogram, which unfortunately is a test that's not available everywhere in Canada. There can also be spontaneous coronary artery dissection, which is not caused by a clot. It's caused by a little tear within the artery wall that then subsequently causes a disruption in a circulation. And this is diagnosed in women most of the time. And finally, small vessel disease can account for some of the cases as well. And for each of these diagnoses, it's necessary to perform a specific test to try to understand whether or not this is the case in this particular woman or patient. We know that for smaller issues with small cholesterol deposits, we might have to do special imaging inside the coronary artery and not just do the one picture that we normally do in standard cases. For vasospasm, we need to do acetylcholine testing or ergonovine testing, which is a test where we put down substances into the artery to see if there is spasm. And this is the test that Majo had that finally led to her diagnosis. For spontaneous coronary artery dissection, we might need to do extra imaging within the artery as well. And for other causes, we need to do other exams, either in nuclear medicine or echocardiogram, or even some blood tests, as well as a cardiac MRI, to be able to properly diagnose women who would otherwise not be diagnosed and wouldn't have an answer. And that's often the most frustrating for women who don't have a standard type of heart disease and who require additional testing. They want to have an answer to why they are having these symptoms. When we think about spontaneous coronary artery dissection, it's a disease that shows us that there's really an interplay between sex-specific risk factors, as well as gender roles and cardiovascular conditions. Spontaneous coronary artery dissection is the #1 cause of heart attacks during pregnancy. Luckily, that is rare. It's also increased in risk when people have high blood pressure, so it's important to control blood pressure. It can be induced by straining or heavy weightlifting. There's also genetic susceptibility, and there can be underlying issues in the artery tree, such as fibromuscular dysplasia, which weakens the heart vessels and makes them more prone to tearing. And emotional stress can be a trigger for these events, as well as very intense exercise or fluctuations in sex hormones. And emotional stress goes along with gender roles for women who are often more often frontline care workers, who are more often caregivers, and who might have a higher degree of stress, especially in the last 2 years with all that's been going on with the pandemic. So that kind of closes off the chapter on ischemic heart disease. We're moving on to heart failure now. So heart failure is the second cause of hospitalization or the third cause of death in women in Canada. What is heart failure? It's different underlying mechanisms which all lead to symptoms such as shortness of breath, either on exertion or when lying down at night, fatigue and swelling of the legs. Predominantly, but sometimes also of the belly. And these symptoms may all be caused by either the fact that the heart is too stiff, what in medicine we call HFpEF, or heart failure with preserved ejection fraction. So it can pump properly, but it can't relax itself properly. And this causes water to accumulate in the lungs and in the legs. This type of heart failure is more frequent in women, who represent over half of patients with this type of heart failure. And unfortunately, this is the heart failure where we haven't done enough studies, and a lot of the studies have been negative, and we don't have very good treatment options to improve symptoms. Other causes of heart failure when the heart is too weak, so that's heart failure with reduced ejection fraction. Women are underrepresented in this disease, but can still be affected, and unfortunately comprise a minority of women included in studies to treat the disease, which means we're applying studies that were mostly done in men to treat women, which can often be suboptimal. Causes for heart failure include previous heart attacks, or toxins such as alcohol, illicit drugs, chemotherapy, and women who've had breast cancer often have chemotherapies that can affect the function of their heart. issues with valvular disease, we'll get to that later, and then genetic as well as issues within the heart muscle itself, known as cardiomyopathies. So we know that women have different risk factors, including hypertension during pregnancy, breast cancer treatment, and their heart will react differently to certain changes, either in blood pressure or valvular heart disease. And this all makes them more prone to have the heart failure with preserved ejection fraction. Generally, women have a greater exercise limitation and a lower quality of life when they've been diagnosed with heart failure, but they overall do have better survival than men, who are more likely to have heart failure with reduced ejection fraction, which means that the heart is weakened. Women represent 90% of cases of a type of cardiomyopathy known as Takotsubo, or broken heart syndrome, or stress cardiomyopathy. What happens in this disease is that there is often a psychological stressor, so grief or anything that's psychologically very stressful. Sometimes it's a physical stressor, which brings on acute heart failure. So the heart is weak kind of overnight from an issue, usually a psychological stressor. One example is when Carrie Fisher, who played Princess Leia in Star Wars, died. Her mother actually a few days later had a case of broken heart syndrome and unfortunately died from it as well. So grief is a common trigger. It's poorly understood. There isn't a lot of studies on exactly what causes Takotsubo cardiomyopathy. Luckily, however, complete recovery is common, but there is a risk of recurrence, and work needs to be done on giving certain medications to reduce the risk, as well as solving psychological stressors, and trying to work on those as well is a big part of it. Peripartum cardiomyopathy is a heart failure that exclusively affects women, either late in pregnancy or in the 6 months following delivery, and it's a weakened heart muscle where the recovery is uncertain, and it can benefit from certain specific treatments. And finally, there are a host of other cardiomyopathies that may affect women or men. Sarcoidosis seems to be more common in women, which is a kind of an infiltration and an inflammation of the heart muscle. And myocarditis has been recently reported in the media with regards to COVID vaccines specifically. That seems to be more common in men, younger men, however. Valvular heart disease implies the valves of the heart. So the heart is a muscle that pumps, and there's 4 chambers in the heart. And between each chamber, there is a valve. And it affects 5 to 10% of adults over 65, and about half of those are women. Women continue to be underrepresented in clinical trials. They have smaller hearts, and often the criteria for suggesting that you repair or change a valve with a surgery are not sex specific, and this might contribute to the fact that women are diagnosed later and therefore have worse outcomes following surgery. Arrhythmias are irregular heartbeats. The risk of having arrhythmias increases in pregnancy because it's kind of our first physiological stress test, if you will. And there's a higher likelihood of certain arrhythmias in women, atrial fibrillation, especially in those over 75. Supraventricular tachycardia can occur linked to the menstrual cycle. Intervals on the EKG that might predispose to arrhythmias seem to be estrogen related. And outcomes in women seem to be that there are more symptoms and that there's a higher rate of recurrence of certain arrhythmias. And women are less likely to be referred, especially when they have atrial fibrillation, for treatments such as cardioversion and ablation. Vascular arterial disease, we've talked a lot about the vessels in the heart, but they're part of a larger system, which includes the arteries that leave the heart. The main one is the aorta, and then it branches off into all the different arteries that supply blood to the rest of the body. We know that the aorta can grow and can have what we call a thoracic aortic aneurysm, which is a larger than normal aorta. Women are less affected by this, but when they are, there seems to be faster growth of the aorta. So it grows faster and is bigger than normal faster. And they have a higher mortality and stroke following surgery as well, which begs the question, should we maybe operate them sooner, because the cutoffs are the same for men and women, and this should maybe be changed. Similar to the abdominal aorta, which can also grow and have an aneurysm and be bigger than normal. And when the aorta is bigger than normal, it has a risk of rupture. So often people need to be operated at a certain measurement. And there can be a faster growth of and higher risk of rupture in women. There are hormonal differences that make so that the aorta in women has higher elasticity, but also higher stiffness and lower strength to react to blood pressure, which with every beat deforms the aorta. And here we've established sex-specific cutoffs for surgery. So there is a difference in management as well. And finally, the arteries that are in the legs and in the arms, peripheral vascular disease. Women are at higher risk of having functional impairment, and they also have a higher mortality following surgery. Stroke. So an ischemic stroke is when there's a blood clot that blocks the circulation off to the brain and causes acute symptoms such as face drooping, arm paralysis, where people can't move one of their arms, or issues with speech. And if you do see someone having these symptoms, it is important to get help right away to prevent any complications and to be able to promptly treat a stroke. Women are over 75 are disproportionately affected by stroke, and they have a higher risk of having disability following stroke with reduced quality of life and increased levels of post-stroke depression and institutionalization. So it's important to quickly recognize these symptoms to be able to provide treatment and prevent this disability following this disease. They also have a possible higher rate of stroke when they have the arrhythmia known as atrial fibrillation. This has been disproved in subsequent studies, so it's still uncertain. But what is certain is that after 65 and with other risk factors, if someone does have atrial fibrillation, they should probably be on a blood thinner unless they can't be because of bleeding issues. And women are also prone to stroke across different times of their life. Preeclampsia is one cause of stroke in pregnant women, and women are also a higher risk of dementia following stroke. So in summary, cardiovascular disease is the primary cause of premature death in women in Canada. Sex and gender unique differences exist in symptoms and the pathophysiology of cardiovascular disease in women. And these differences must be considered when evaluating cardiovascular disease symptoms because they affect management and prognosis in women. Thank you so much for your attention, and I'm looking forward to the discussion panel.
Okay, thank you so much to both of you. That was just amazing. I'm just writing down comments as you're going, so it means that as comments that Bobby Joe said, comments that you said that are, it's so important for all of us, but also that the confluence again of the sex and gender. It isn't just the sex and the biological differences, which you really clearly laid out, but it's also these other gender differences that are happening that we all have to be aware of and pay attention to. So we do want to hear from everybody. Before I go into the question period, I just want to remind you of that you will be getting an evaluation link, please. But due to the nature of this public forum, we ask that you keep your questions general in nature. But to start off with, when we reflect on Bobby Joe's story and Christine Pacheco's presentation on the sex and gender aspects of it, I'd like to ask you both to think about what we can or could or should be doing differently in order to recognize this. And I know, Bobby Joe, you mentioned, just searching for someone to believe you. So one of my first thoughts is that we need to make sure the awareness is out there that this is going on. But maybe over and above this, Bobby Joe, what would you comment about what could we do differently? What should we be doing differently?
For me, it was just education. I needed people to know that, I needed the physicians to know that the right-sided chest pain can be, related to your heart, and that chest pain at rest can still be your heart. So for me, it was the biggest thing where I was presenting, again, I don't like to use the word, but I was presenting atypically. And that's what was steering them away from my heart. Right. So I was having the heart issues, like I was having the chest pain, but I was also having the burning in the shoulder blades and the burning shoulders, the pain in the back, the tooth pain. So it just kind of seemed like a mixed bag of tricks, I think, to a lot of my physicians who were kind of like, where do I even start with this? But, knowing what I know now, when I look back at it, I'm like, holy smokes, like this was heart right from the beginning to the end. Right. So for me, it was just better education, and especially at the ER. The emergency was and still remains now, like I would like strict instructions for my family. Like, you don't call 911 unless you think I'm actively dying, because it's just a horrible place to go with browbeating and gaslighting and treating you poorly. When you go in with atypical chest pain. So for me, it was just education and having them listen to my symptoms and not rely on tests, because for me, my tests were normal across the board most of the time.
Yeah.
Except for that provocative angiogram that showed, several things happening. So.
Yeah. And without your persistence, like to put up with that, I fully appreciate that it's the ER that we really need to focus on, right? Or primary care in general, like that your first stop, the first entry. Christine, what about you?
So I definitely think I've, and your story and other women's stories, it's so frustrating that you have to keep going back and going back and going back. And, I think listening is the first thing. As a physician, I think that's what we need to do and be better at, and listen. And I think when, Dr. said, like, listen to your story all over again, and had, the whole, I think that's number one. I think we need to listen better as healthcare providers. Firstly, I also think, knowing what I know, and I obviously have a specialized background, with the EKG changes you were describing on your first episode, that should have put people kind of closer to the hint that, something cardiac was going on as well. In addition to the pain that you were presenting, that, yeah, it wasn't typical on exertion, the whole story, but it was definitely cardiac in nature. And now, I think we have more information. Could maybe some therapy been started earlier on to see if it gave you at least partial symptom relief. And so I think when women come back and back and back, and they keep having chest pain, they merit our attention, our listening, and they also need us to go a little further in the diagnostic tree. Not just stop at the EKG and the troponins and then, okay, maybe go down that a bit more. The stress test was initial step, but now we know that there's way more diagnostic tests than can be done to try to understand why you're having chest pain, and even trial medications to try to help your symptoms and reduce them. And I think there is some progress, but it's slowly but surely. When I went on fellowship 5 years ago, so it's not that long ago, when I was leaving, people were like, what's women's heart disease? And now, we have an alliance over 120 members, and these publications, and the chest pain guidelines of the ACC are incorporating new terminology that will advantage women like you. So I think there's progress, but it's slowly and surely. And I think, as an alliance, we're definitely part of that. So yeah, that would be my takeaways from this. And if you have anything to add, Bobby Joe, I'd love to hear it.
No, I'm with you. I'm with the listening. The listening piece was key. For me, it was just relying on the test results and not listening to what was actually happening.
The other thing too, when you bring up the test results, it reminds me of when I was having my third baby, and the heartbeat kept dropping out, and they kept changing out the monitor because there must be something wrong with the monitor, right? And it kind of reminds me of your ECG story. Okay, like that's not what we expected to see, so let's change the ECG machine. And so maybe I think that's part of the root of the problem is the protocols say ECG troponin, ECG comes back normal. Well, the machine can't be wrong, so it can't be your heart, right? So we have to stop relying on that in female specific cases, for sure, right? Like protocol for females should be, it won't necessarily show up as an ECG, and that's the education that we need to do. Sharon,
Yeah,
There is-
I can't help but jumping in there and just saying that I think that something that Bobby Jo said, amongst all the things that were so profound, was that she didn't fit the picture. She got the message that she didn't fit the picture. And then she became basically a problem patient. The internist sighed deeply before he came in to say. So it is so imperative that we educate our healthcare providers to be able to know that heart disease can present differently. And we have to think beyond the causes of the traditional things that we see in men when it comes to the pathophysiology of heart disease in women. And for our women patients, it is imperative for them to continue to be advocates for themselves. Thank God for that support group that you found online through Facebook that really helped you enormously. And so we are growing this and growing it more, and through our grassroots patient advocates themselves that are doing this, as well as being supported by our national organizations such as the Women's Heart Health Alliance, as well as Heart and Stroke. So I have to be the bad cop now because I'm getting the pressure from the boss here to say that we have to wrap up today, but I just can't thank both of our speakers enough. Bobby Jo, thank you so very much. And I'm so glad that your story has had a good outcome. And thank you for all that you are doing to advocate for women with cardiovascular disease by sharing your story. And Christine, Dr. Pacheco, thank you again for going over a huge amount of detail in a very succinct way to be able to share more information with our healthcare providers, as well as our patients, to know what to say and what to ask for to be able to be heard and listened to. So the PDF of the slides will also be available at the website. And we also will remind you that the actual webinar will be available online to review again within about a week. I would like to remind you all just one more time to please take the few minutes to fill out the evaluation, because we really do utilize your comments and appreciate your participation in the session. I'm sorry that there weren't, I didn't see any Q&As here, so everybody was just in dumbfounded, I guess, today. We didn't have any questions from the audience, but if you do think of things afterwards with questions, please feel free to email us at the CWHHC@ottawaheart.ca email address, or you can link to that as well at the Heart Alliance website. And we will do our best to answer and direct you for information resources. So thank you so very much for joining us once again today. And we'll look forward to our next webinar as it comes up with the next chapter. We have what, three left, I think, to do, right, Colleen? So that's wonderful. And thank you all again. Have a great day. Take care, everyone.
Thank you very much, everyone.
Thank you.
thank you,
Bye.
thank you. Bye.